Next is tumor lysis syndrome. It's simple. If someone has history of hematological malignancy and they are getting chemotherapy inpatient, so the chemotherapy will break the tumor, and as a result, different electrolytes will be released from the tumor, which will cause kidney injury. So let's say this is a tumor. We started chemo. The tumor will break down, cause the release of potassium, phosphate, uric acid. So that will result in electrolyte abnormality, which can cause AKI. Pathogenesis, you start chemo or radiotherapy. Rapid lysis of tumor result in tumor lysis syndrome. Release phosphate. So phosphate concentration will be very high in the body. So normally the phosphate concentration is low in normal cell, but in malignant cell, normally the phosphate concentration is very high, 4 times higher. So phosphate will be released. It will bind with calcium, results in calcium phosphate stone, or it will result in precipitation of calcium phosphate into the renal tubule, which can cause AKI. So tumor breakdown will release purine, which will be converted into uric acid. So overproduction of uric acid result in uric acid crystal formation in renal tubule, which will cause AKI. Tumor breakdown will release potassium, which will cause hyperkalemia, which we'll discuss in detail later, how to treat hyperkalemia. Clinical feature from electrolyte abnormalities, they can have nausea, vomiting, diarrhea, hematuria from kidney stone, can have heart failure, cardiac arrhythmia, seizure, muscle cramps, tetany because of electrolyte abnormalities. They can have syncope and possible sudden death. So treatment, we have to give them fluid to maintain urinary output of at least 100 to 80 to 100 ml an hour. So I will say you can put them on 150 to 200 cc an hour. Normal saline. Your urinary output should be 80 to 100 ml per hour. You can tell the nurse to monitor that. There is no evidence that alkalization of urine will be helpful. If uric acid is high, you can start this patient on allopurinol, rest uricase, the buxostat for hyperuricemia. For high risk patient, so patient with AML, CLL, Burkitt lymphoma, you can use rest uricase. It should be given first before allopurinol. And for low risk patient, in which the uric acid level is low, not too high, you can give allopurinol. What's the mechanism of rest uricase? It converts uric acid to allantoin, which is inactive and soluble metabolite of uric acid. That's the mechanism of rest uricase. Treatment of established tumor lysis syndrome. So patients who have tumor lysis syndrome, monitor them in ICU, maintain electrolyte, maintain creatinine, uric acid. So you have to check electrolyte every 4 to 6 hours. Check CBC, BMP, phosphate level, uric acid level every 4 to 6 hours, and correct as needed. So if the patient develops severe AKI, they might need dialysis. Takeaway points. So tumor lysis syndrome common in patient for hematological malignancy. They are getting treatment. So they require IV fluid, electrolyte management. No role of urine alkalization. So for elevated uric acid, the options are allopurinol, rest uricase, buxostat. So this is tumor lysis syndrome.